Hello and welcome to everybody to this joint webinar, which is an initiative of the Acute Leukemia Advocates Network and the CLL Advocates Network. For anyone who doesn't know me, I'm Zach Pemberton-Whiteley. I'm chair of the Acute Leukemia Advocates Network. I'm delighted to be co-chairing this webinar alongside Pierre Ormond from France, who is the vice chair of the CLL Advocates Network. Delighted to have so many of you with us here on Zoom and also on Facebook. I'll cover a couple of matters of housekeeping at the start, and then I'll hand over to Pierre, who's going to introduce all of our speakers. So a couple of housekeeping notes. You will be all muted throughout because we've got quite a lot of people joining us, but if you want to ask a question, please do so either through the Q&A or the chat. We've had a lot of questions in advance of the webinar, so we're going to try and cover some of these as well. But you're welcome, and we really encourage you to ask questions as much as you want throughout. It's intended to be interactive, so post them in the Q&A and chat, and we'll ask all of those really difficult questions to our expert speakers. The webinar is being recorded here on Zoom, but also broadcast live through Facebook. So if anybody has to drop out or wants to share any of the information with colleagues, you can do so at a future time. So looking forward to a really exciting discussion, and I'll hand over to Pierre.
Thank you, Zach. Thank you, everybody, for attending this webinar. I think the topic is quite interesting. The long-lasting pandemic, the treatments, the specificities of the CLL patients, and of course, the vaccines are at the top of the news now. So we have invited 4 speakers, 2 clinicians, 1 regulator representative, and 1 epidemiologist. And I have the pleasure to introduce our first speaker, Professor Florence Cymbalista from France. She is our CLL expert today. She is well known in France and a specialist of this disease, and also active worldwide. Professor Cymbalista is head of the Hematology Biology Department at Avicenne Hospital, that's near Paris. Our acute leukemia expert, Dr. Amit Patel from the UK, is the first person in the UK qualified in stem cell transplantation and cellular therapy and intensive care medicine. He is the lead clinician for hematology and transplant research at the Christie NHS Foundation Trust. Dr. Julio Delgado is originally from Spain, where he works at the Department of Hematology of the Hospital Clinic in Barcelona. In his role as second national expert at EMA's oncology office, he is currently based in the Netherlands and is joining us today to give the regulator's perspective. Professor Uwe Gert Liebert is a German virologist and a retired professor since end of 2020. He was a director of the Institute of Virology at Leipzig University Clinic, and he is a highly respected and expert. So I thank you very much, all speakers, and welcome you very warmly. And now give the floor for her presentation to Professor Florence Cymbalista.
Thank you, Pierre. So I'll put my slides on. Is that okay? Okay, so I'll try to be brief because I have quite a few slides, but I thought that you might share them later so people can have a look at them. So I'll go. You're very welcome to ask any question. So first we'll see COVID and CLL, and then we have a word about mRNA vaccine, and then how we're going to manage. So first, regarding COVID-19, there was a European study studying the epidemic wave, and conducted by the ERIC, and mostly in Italy and Spain, around 190 patients. And what we can say is that considering the median age of 72, and that the fact that most of the patients were comorbid, the high mortality rate among the hospitalized patients was kind of expected, but it seemed to be higher still to the one that was reported in the general population, but I'm not sure that the 13.4% were really related to the 72 years old. So there was a short report from the German group about 6 patients who were receiving venetoclax, and 2 of them were admitted in ICU and died. There is also an American study of about the same number of patients, 198. And what's interesting in that study is that they have the similar rate of mortality, but it seemed that receiving a BTK inhibitor for CLL at COVID-19 diagnosis severe enough to require hospitalization did not influence this mortality, and it was the same among the watch and wait and the treated patients. So we have conducted a study in France as well. It's unpublished data, but what's important in the 2 studies that I presented is that they were mostly focused on hospitalized patients. And all the patients who did well at home, and even the ones that were asymptomatic, are not considered. So in the French cohort, we observe a similarly high mortality rate of hospitalized patients, but we also had a lot of patients who were treated at home, and even asymptomatic patients, even among elderly patients. But what was obvious is that the risk factors, age, diabetes, hypertension, obesity, that were identified in the non-CLL population had exactly the same importance in CLL. COVID-19 treatment was exactly the same for CLL and non-CLL patients. And what's interesting is there were 2 trials during the epidemic wave, one with ibrutinib and the other with acalabrutinib, that had been proposed to non-CLL patients to contain the cytokine storm. It doesn't seem that it was beneficial, but it was not detrimental. So what about the CLL treatment during COVID? Well, there is now, I think, a quite strong consensus among the recommendations from the various national groups. The treatment, if it's ongoing, should not be discontinued outside of very severe infection in ICU where it might be necessary. For the patients in need of treatment for CLL, it is recommended, if it's possible, to postpone the initiation, if possible, until after vaccination. When the treatment cannot be further deferred, well, we have been giving preference to systemic therapy requiring fewer visits during the waves, during the epidemic waves. And I think that there is a consensus to try to use a less immune suppressive therapy. And we have limited the anti-CD20 infusion. And in France, where we still use quite a lot of chemoimmunotherapy in frontline, it has been replaced by ibrutinib during the waves. We also try to limit the routine lab samples. And for the patients who are receiving immunoglobulin supplementation, the IV route has been replaced by sub-Q. But we have been also cautious to maintain the vaccination programs against influenza and pneumococcus. So there is also vaccine trials outside of CLL. I'm not going to go through it, but what's important to see is that overall mRNA-based vaccines have shown over 90% protection from COVID-19 disease with a very good tolerance. It's not so high for an adenoviral vector-based vaccine, but it's still quite good. So what do we know so far in patients? I would say absolutely nothing. But we can we extrapolate for some of the works that have been done with other vaccines? Well, there are very few data on vaccine efficacy in patients with CLL, but there is enough evidence also through real life to support in anti-infective vaccination in patients with CLL, because even if there are suboptimal responses that have been shown in some trials, it reduces hospitalization rates and it prevents serious disease complication, and that's exactly what we want in COVID-19. So which vaccine? Well, considering the recent recommendation of several European countries to use AstraZeneca only for younger patients, it seems reasonable anyway to prioritize mRNA vaccines. So what are the various vaccines? Well, you have the Moderna and the Pfizer that have been approved that are mRNA coding. And the viral vector is the AstraZeneca, and currently we don't have any approved recombinant protein. So briefly, how the mRNA vaccine works, have been using these cartoons from the New York Times, because I think it's quite easy to understand. I mean, the mRNA that is injected is wrapped in lipid nanoparticles that allows it to enter the cell easily. So it enters the cells at the site of injection, and the cells uptake the mRNA and translate it immediately in a spike protein. This spike protein is expressed at the surface of the cell, and here, and you see here that as soon as the cell dies, which happens regularly because they are replaced, I mean, there is an antigen-presenting cell, like a macrophage, that digests the spike and re-express and presents a fragment that is able to be recognized by an immune cell that is a T lymphocyte, a helper T lymphocyte. And this helper T lymphocyte is very important for the activation of the B lymphocyte, which in turn will be able to secrete antibodies against the spike protein. So how the spreading of the virus is stopped? Well, we always talk about the antibodies attacking the virus, but there is also another way. There are the killer T cells that seek out and destroy any coronavirus infected cells. You see here the killer T cell. So what are the typical immune challenges that CLL patients are facing for this vaccination? Well, there are a reduced number of normal B cells because they are replaced by the clonal lymphocyte of the CLL. And also we know from previous study that there is a not so good B and T cell cooperation that is needed here to activate the B cell. And if there is previous treatment, the helper T cell numbers might be affected as well. So there are different levels of problems. What have we seen from studies in other vaccine? Well, protective effects are reduced in CLL-treated patients, but the 3 recent studies that I have found in PubMed are conducted on quite a small number of patients each, around 30 patients. And there are some discrepant results on the VZV vaccine, and exploration of the response is limited to antibody production. And I don't think that's the whole story. So can we extrapolate these results of mRNA SARS-CoV, the vaccination from works done in other vaccines in a certain way, because they are not live vaccines, and it's conceivable that the safety might be similar and also the efficacy. And so we may expect a reduced efficacy of the mRNA vaccine, notably in the patients who are on therapy, but concerning the safety, there has been mRNA-based vaccine against some cancer like melanoma for the past 10 years, and they have not raised specific safety reassured. Well, on another hand, we cannot extrapolate, but because it's not the same mechanism, but there is hope. I would say that mRNA vaccines might work better than traditional vaccines. First, there are promising preliminary data in non-CLL patients that are extremely good. The studies so far have focused on B-cell responses, but it's obvious that T-cell immunity is likely to play an important role in vaccine efficacy as well. And there might be an advantage, but that's very theoretical, of mRNA vaccines, as the protein processing may allow better recognition by the patient immune system. So what are the recommendations for vaccination? Who should get the vaccination? I think that we all, physicians, we all agree that all CLL patients should get the vaccination. And in high priority for the patients with ongoing treatment and the patients who had previous COVID infection, they may be vaccinated, but at least 3 months after infection. Which vaccine? Well, there's a consensus currently to consider that the mRNA vaccine is most appropriate. While the use of AstraZeneca has been restricted in many countries like France to patients below 65. And of course, there might be new options with the release of other vaccines. So when should the patient be vaccinated? Well, prior to starting therapy if possible, and if the patients who are already on therapy anytime. Treatment should not be discontinued, and the option that our French immunologists are very keen upon is that the second dose should not be delayed for immunocompromised patients, maximum 4 weeks after the first dose. Are there contraindications to vaccination? Well, there are very little. The only contraindication is a severe allergic reaction at the first dose, or an immediate allergic reaction of any severity to 2 components of the vaccine, which are polysorbates and polyethylene glycol. Concerning the allergy, a lot of patients are allergic, and the only real caution that we should have is for patients who had a prior severe allergy to injectable therapies or iodine, and it's recommended to vaccinate these patients in allergy specialized centers. Otherwise, there is no specific precaution for any other allergic reactions, including severe anaphylactic reaction to food components or environmental allergies or to oral medication. And it's important to know that vaccines contain no egg, no gelatin, no latex, and no preservatives. I think the only caution that we have as CLL doctors, there is absolutely no basis for that, but we are just cautious on the safety and efficacy of mRNA vaccines in persons with autoimmune conditions, but we don't have any signal, unfavorable signals from clinical trials, but it's just a caution that we are thinking of. So the CDC has given a recommendation for immune-compromised patient post-vaccination that are exactly the same as the public health recommendation. We don't know exactly actually how much the mRNA COVID vaccines may reduce transmission in the general population. We don't know how long the protection is going to last. So it's important that the vaccinated persons should continue to follow all current guidance to protect themselves and others. And well, you know what it includes: wearing a mask, washing hands, and so on. And the last point is that given the lack of data on the safety and efficacy of mRNA COVID-19 vaccines administered simultaneously with other vaccines, it has been recommended that a minimum interval of 14 days should be respected. Okay, so I tried to be brief. I don't know if I succeeded, but I'm done.
Okay, thank you very much, Professor Simbalista. The question will be asked at the end of all presentation. So that I give the floor now for our acute leukemia expert, Dr. Amit Patel. The floor is yours.
Thank you very much for such an excellent overview of the vaccines as well as the limitations in terms of the available data. I'm going to speak a little bit about the situation for patients with acute leukemia, including those treated with hematopoietic stem cell transplantation and available CAR T cell therapies. These are my disclosures here. So if we then start the journey really looking at, well, what is the outcome of patients with acute leukemia that get COVID-19? I think what we can see from the data here is that there is an age distribution that's similar to the general population. In other words, older patients tend to, unfortunately, have a higher risk of dying in relation to infection. There's a similar relationship with more men dying compared to women in relation to COVID-19 in the AML and ALL.
Apologies to interrupt you, Dr. Patel. We can't see your slides. For some reason, it's just showing us that you're screen sharing. And I think a couple of the attendees are having that issue as well. So maybe you could turn the slide screen off and then turn it back on again.
Sure.
Same for me, Zach. Perhaps Nicole could share the slides of Dr. Patel.
Yeah, otherwise I'll
whatever you like. You can try again. If it doesn't work, I'm happy to jump in.
Okay, so I hope everybody can see that now.
No,
I
actually,
can't.
fine.
Yes.
Now we do.
Oh,
Now
that's
we
There
do.
we go.
Perfect.
Yes, okay. So these are the data in patients in a US repository, and these are patients with acute leukemia. You can see the older patients have a higher risk of dying. You can see that in the red bars here, in the 40 to 65 and greater than 70 age group. More men compared to women are unfortunately getting the infection. And the type of comorbidities that are associated with infection are the ones that are reported in the general population. So diabetes, hypertension, some autoimmune diseases, some other chronic renal and lung diseases. So in the main, actually, the outcomes are not that dissimilar to those patients in the general population in relation to the pattern of infection and the outcome from infection. In relation to transplantation and cellular therapy, you can see here the number of patients that have been reported in the registry in relation to these therapies is low. But if we take them in turn, you can see that there is a high rate of non-survival outcome in patients post-CAR T therapy, mainly for ALL, and patients post-allogeneic stem cell transplantation, mainly for AML, and also autologous transplantation in addition. If we think about how to manage these patients, I've already said that the outcome is largely dependent on the outcome in relation to similar members of the general population based on age and comorbidity. And so in the UK, we have an algorithm which we use for all patients. So anybody who has an oxygen requirement gets treated with dexamethasone based on the pivotal data from the recovery study. And that provides a survival benefit in the ICU and outside of the ICU. We also treat patients with remdesivir if they meet certain criteria. And because there were no significant survival data showing a benefit with this drug, the use of this is selected. And then more recently, data released from the REMAP-CAP trial in the UK showed that tocilizumab and sarilizumab, interleukin-6 inhibitors, used within 24 hours of organ impairment requiring critical care unit support conferred survival benefit with treatment. So now we use this. And this algorithm is exactly the same as the algorithm we use for the general population, and we use the same algorithm for patients who have acute leukemia, whether they're in the post-transplant state or the post-CAR T state. If we then look at vaccines, and we've heard a very nice description and detail of the vaccines, I suppose when it comes to patients with leukemia, actually only the Pfizer vaccine reportedly had 76 patients with leukemia and lymphoma. We don't really have any more details in relation to this. None of the other vaccines, as far as I understand, had included these patients, or at least knowingly included these patients. We know that only the Pfizer vaccine can be used in patients that are 16 years of age or older. Otherwise, the other vaccines are only tested in the adult population. And you can see the efficacy post-dose 1 and post-dose 2 shown here. And these data are taken from the British Society for Blood and Marrow Transplantation and Cellular Therapy in a recent update. What about the transplant and cell therapy population then? What do we expect are the outcomes in this group where the data are very sparse? This study from the US reported in 77 patients who had been treated with one of these forms of cellular therapy. But actually the outcomes were favorable for patients who didn't have uncontrolled disease. Patients actually had a good treatment course with half of patients treated in the outpatient setting, so non-severe COVID. Antibodies were detected, even in sometimes when contexts when the B cell numbers were low. And we've heard a little bit about the importance of T cell and cellular immunity in addition to antibody-mediated immunity. And the other thing that was found was there was actually a reduction in lymphocytes following recovery post-infection. And so a typical pattern of lymphocytes might be an increase after the cellular therapy in question, infection, which then drives down the lymphocyte count, and then during recovery, the lymphocyte count recovers. In that particular study, you can see here in terms of survival, all patients post-autologous transplantation had the best and highest survival out to almost 60 days here. And patients post-allogeneic stem cell transplant or post-CAR T cell therapy, although the numbers of patients are small, had a similar outcome, which was probably inferior to those patients post-autologous stem cell transplant. And that's not surprising because these two groups, allo transplant and CAR T therapy, have a long and severe immune paresis. And you can see that here. When you look at B cell numbers, CD19 is a B cell marker, you can see that B cell numbers in the small number of CAR T patients was 0. You can see it was around 50 in those who had an autologous transplant. And you can see it was low at a median of 8 in those who had allogeneic stem cell transplant. So based on B cell numbers, CAR T patients are the most vulnerable, followed by allo transplant patients, followed by autologous transplant patients. And in terms of T cell immunity, so CD4 and 8 cells, you can see again that in the post-CAR T cell space, CD4 numbers are the lowest amongst all the forms of cellular therapy. But actually CD8 numbers are slightly higher, and that's not surprising because the cellular therapy itself might be expanded, and that might inflate the numbers of CD8 positive T cells that are present. You can see in the corner here that if you follow the PCR viral load, you can see actually that it's variable in different patients. Each line is a different patient, and it can persist as positive for a long period of time. If we take a few examples of individual patients now, you can see lots of different patterns emerging. So on the left-hand side, you can see a patient who's early post-allogeneic stem cell transplant. Around the day 100 mark, you can see that their total lymphocyte count shown here in purple drops with viral infection, and you can see PCR positivity occurring. This is in the context of somebody who's still on immune suppression, has got graft versus host disease. You can see that an antibody level taken some time later remains negative. PCR positivity remains and then becomes negative. And associated with that is recovery of the absolute lymphocyte count. And you can see the B cell numbers shown in dark purple right at the bottom stay relatively low. So in other words, you don't need B cell numbers to be high to clear virus, but you can see that this patient did not mount an antibody response subsequent to infection. On the right-hand side, however, what you can see is a different patient who gets infected, has the lymphocyte count drop, and then despite recovery of the lymphocyte count to higher than pre-infection, the patient remains positive for COVID-19. So PCR positivity remains for a long period of time, almost a year after the infection. And the second, almost 100 days after the infection. And what you can see is that the positivity remains despite the fact that this patient has got an antibody response, IgG positivity has occurred. And this patient received tocilizumab as part of their treatment for COVID-19, and they were on ongoing immune suppression. These two illustrate slightly different patterns. Here you can see a patient who has PCR positivity, lymphocyte count drops, B cell number, CD19 in dark purple at the very bottom stays quite low. PCR becomes positive, then becomes negative some time later. And just before the patient clears virus, they develop an IgG antibody response that's positive, and soon after that becomes negative. So they have a short-lived antibody response. The patient on the right-hand side, you can see, has got graft versus host disease, is on significant immune suppression, and is early post-transplant. And what you can see here is this patient does not clear virus, and this patient does not mount an antibody response. And to finish now, we've got somebody who's got a variable lymphocyte count, despite the fact that's shown in the top light purple curve. And despite that, you can see the B cell numbers remain flat at the bottom. However, this patient is able to clear the virus and mount an antibody response without detectable peripheral blood B cells. And the last patient, who is many, many years out post-transplant with their leukemia, has recovered from their disease, is in long-term remission, develops COVID-19, is treated with some steroid, and then recovers. And during the development of COVID-19, you could see a drop in the lymphocyte count, which recovered. What's interesting is that their B cell numbers are normal, so dark purple. They drop during infection, and they don't really recover well some time after infection. So in fact, the B cell numbers in patients post-allo transplant may take a longer time to recover, maybe many months, maybe 6 to 12 months before that occurs. And that has implications for other types of infections as well. If we think about transplant activity and CAR-T activity, you can see from this graph, taken from data from the European Blood and Marrow Transplant Registry, that despite the COVID-19 pandemic in the UK and across Europe, there's been really very little change in the trajectory of the increase in CAR-T patient infusion. That's in contrast to patients who have presented with acute leukemia for the first time. And that's also in contrast to patients who have gone on to receive allogeneic stem cell transplantation for acute leukemia, where there's been significant impact of delays, both in terms of access to donors, particularly unrelated donors, and to some extent related donors, mainly because of deferral due to COVID-19 infection. If we look at the complexity of CAR T-cell therapy for acute leukemia, what we can see, and these products can be used in clinical trials for CLL, what we can see is actually the manufacturing after a leukapheresis procedure, which takes a number of weeks, can become interrupted in terms of supply chain and in terms of COVID-19 infection in the source of the cells, so the patient, and also in the staff looking after the patient and involved in manufacturing. Therefore, in terms of the impact and immune recovery post-cellular therapy, what we can say is that it can impact all stages of the patient pathway, from procurement of cells prior to genetic modification, or procurement of donor cells prior to transplantation, infusion of the cellular therapy, whether that's CAR-T or transplantation, and then long-term recovery in the medium and the short term as well. And it's important to note that even if infection occurs post-infusion or pre-infusion, there is going to be an impact both from an immunological response and in terms of a logistical and facilities response as well. I'm going to stop there. Thank you very much.
So thank you, Dr. Patel. Now the voice of the regulator with Dr. Julio Delgado. Please take the floor.
Thank you. Thank you very much for your kind invitation. So my name is Julio Delgado. I'm a hematologist, but currently working at the European Medicines Agency as a seconded national expert. So we all know that drugs in general need to go through a number of steps to be developed and approved, and COVID-19 vaccines are no exception to that. Next one, please. I'm not going to go through the whole process because you all know what it entails, but I would like just to highlight the fact that normally one process starts when the previous one ends. So for instance, if you do non-clinical research, once you've completed non-clinical research, you start with phase 1, then if you complete phase 1 trial, you go for phase 2, and so on and so forth. So this is what normally happens for any drug that is developed. The next. For COVID-19 vaccines, things have changed. And you can see that all the different processes and steps are sort of superimposed. And this has been accomplished by something that is called a rolling review that I'll explain in the next slide. So rolling review is used in situations like this one, like public health emergencies, and allows the EMA to evaluate data as soon as it is available. Several rolling review cycles can be done as data continue to emerge. So the EMA receives one batch of data and can evaluate it, and then the next step, and then the next step. So the regulator doesn't have to wait until everything is done to carry on the evaluation. And you see here the difference between the standard way of evaluating drugs and the rolling review that's taking place for all the COVID-19 vaccines. Next. But it is very important to highlight the fact that COVID-19 vaccines are approved according to the same standards that apply to all medicines in the EU. So the fact that these drugs have been evaluated in a different way with such rolling reviews does not mean that the standards are compromised in any way. When regarding evaluation and decision, the next one. The EMA has decided that these drugs, these vaccines, would be granted conditional marketing authorization. And this type of authorization is not new. It's not something that was made up for COVID-19 vaccines. It's been there for many, many years. There are many oncology drugs that have been approved as conditional for conditional marketing authorization. For instance, polatuzumab comes to mind. When it was approved for the treatment of diffuse large B-cell lymphoma, it was using this path. These conditional marketing authorizations are for medicines that address unmet medical needs, and the benefit of having these drugs available immediately outweighs the risks of doing that before having comprehensive data. Again, this is for medicines intended for treating, preventing, or diagnosing seriously debilitating or life-threatening diseases, and also for public health emergencies. And I'm sure you all agree with me that COVID-19 disease fulfills the whole thing. It's a public health emergency. It's a seriously debilitating and life-threatening disease. What is very important about conditional marketing authorization is that the company commits to providing further data after approval. For instance, long-term safety data that generally is not available by the time the drugs are submitted for marketing authorization. So one of the key aspects of conditional marketing authorization is this, the commitment that the company, legally binding commitment that the company makes in providing this long-term safety data after approval. So again, Why the EMA decided to go for conditional marketing authorization? Because it's a formal approval of a medicine across the EU. That means that all member states benefit from the joint scientific assessment and approval. So no member states are left behind. Everybody gets the drug approved at the same time. Despite that being, let's say, fast, it has all the safeguards and controls in place to ensure high level of protection. And again, things that are important for conditional marketing authorizations. There must be a robust monitoring plan for managing safety. There has to be a clear legal framework for evaluation of efficacy data. There must be manufacturing controls, including batch controls for vaccines specifically. Of course, there has to be a clear package leaflet and SMPC available, and this is of course evaluated by the committees. Very important as well, there has to be a plan for use of the vaccine in children. All drugs that are granted conditional marketing authorization have a pediatric plan agreed. And you know, this is particularly important because all vaccines approved so far have been approved for people older than 16 in one case, or over 18. And again, additional studies or other data that the company is legally obliged to provide with defined timelines. So that these are the reasons why the EMA decided to go for conditional marketing authorization for all COVID-19 vaccines. In terms of manufacturing, next one. Something that happens normally is by the time of approval, the production capacity for any given drug is small, and it builds up with time. Here, the manufacturers are under a lot of pressure, and it's a bit the other way around. So they need to have production capacity built up by the time the drugs are approved, and this is putting the manufacturers under a lot of stress as well. Next one. In terms of safety monitoring, this is another key aspect, and EMA is working hard to have comprehensive safety monitoring and risk management. And this is all within what is called the EU pharmacovigilance system. And here we all play a part. So patients are important for monitoring safety of these new vaccines. Of course, healthcare professionals, regulatory agencies, both at the European level, but also at the national level, and then national healthcare systems, and obviously marketing authorization holders. Next. Another aspect that is very important for the EMA is transparency. And I have to tell you that the EMA has gone through it's taken exceptional measures for COVID-19 medicines. So here in this table, you can see the difference between what is standard practice, what is the information that the EMA typically publishes for any drug that is approved, and how these measures have been increased for COVID-19 vaccines. So for instance, scientific advice, for any other drug, there's no information whatsoever about what drugs are being advised or not. For COVID-19 vaccines, there's a list of medicines, and that list is publicly available, showing all the drug companies and vaccines that have been advised. Whenever a rolling review is that is also publicly announced. So for instance, last week, the EMA announced that there's another vaccine that is currently being evaluated, the Novavax vaccine that was announced last week. This doesn't happen normally for other drugs. In terms of the marketing authorization application for standard practice, this is generally, that information is available in an active substance list in the medicines under evaluation. For COVID-19 vaccines, the announcement is published within 1 day of application. So again, expediting all the time that takes to publish all that information. The EPA, the European Public Assessment Report, is generally published sometime after the drug is approved. with the EPAR, and for COVID-19 vaccines is again published very fast, the product information within 1 day, and the EPAR ideally within a week of the marketing authorization. And finally, monthly safety reports. These are normally not published, but for COVID-19 vaccines, they are published monthly. And indeed, the EMA has already published the first safety update for the first vaccine approved, the Pfizer vaccine. That was published last week as well. So next one. In relation with patients with cancer in general, or leukemia or lymphoma, this has been stated already. The truth is that patients with cancer require an active therapy, and immunocompromised patients were excluded from pivotal trials. We know the information from the Pfizer pivotal trial. We only have that information, as Dr. Patel mentioned, that around 4% of patients included in the Pfizer pivotal trial had a prior history of malignancy. We know that they didn't have active treatment at the time because they would have been excluded, but they at least had that history of malignancy. We also know that although these people may not respond well to the vaccine, there are no particular safety concerns. So there's no expectation for these patients to have any safety problems. And this is why the EMA concluded that the benefit-risk ratio for patients with cancer or immunocompromised patients is positive, and therefore is recommended. There's no formal contraindication or anything like that. Next one. So I'm just going to conclude here to say that COVID-19 vaccines, the same assessment was performed as for any other medicines. The timelines were shortened thanks to rolling review, but the standards were the same for quality, safety, and efficacy. And the EMA is following the conditional marketing authorization route. That again is not a new thing. Is a process, is a tool that was already available for drugs in the European Union. Exceptional measures are taken to maximize transparency for COVID-19 vaccines and treatments as well. So the same applies not only to vaccines, but any treatment that is intended for COVID-19. Again, a strong EU pharmacovigilance system is in place so that safety will not be compromised. And again, in terms of safety, this will get better if we all help and provide information on problems that we may encounter with the use of vaccines. Thank you very much.
Thank you so much, Dr. Delgado. Now it's time to tell us the story of the viruses. Professor Liebert, you have the floor.
Okay, thank you for the introduction and thank you for inviting me. And let me just start. Could you just show the next slide? Okay, the topics I'm dealing with is, of course, how do these coronavirus mutations occur? And this is probably the major topic of what I'm talking about today. I will come back to the next questions as well. So if you look at the genomic similarity of the human SARS coronavirus 2 and the origin of the virus, this bat coronavirus, then you see that the bat coronaviruses in this region and here differ to some extent from the human coronavirus. The difference is particularly in the transcription machinery, and is less important in the surface gene in that region that codes for the spike protein. Next slide, please. Okay, how do viral mutations occur? First, to start with, is these are events that occur at random, and they are naturally occurring. It's nothing that you so somehow forced to happen. And it's the case that most of the RNA viruses do not have a machinery to exclude or to repair mutations. Mutations are probably just errors by multiplication of the viral genome. The coronavirus has such repair mechanisms, and that's why the mutation rate is lower than it is in usual RNA viruses. What we have, there are two different types of mutations. There are silent mutations and missense mutations. The silent mutations mean that there is a change in the nucleotide sequence, but no change in the proteins. So only the missense mutations do change the protein composition. And these changes could be, in view of the virus, disadvantageous, so the virus is somehow dying or is less fit for replication, maybe insignificant, or it may be, in view of the virus, favorable. And it's only these favorable mutations that are giving rise to concerns, because these favorable mutations may potentially have an impact on the transmissibility of viruses, the mortality and lethality of a virus-induced disease, and of course, towards the vaccine efficiency. Yeah. So if you look at this, and probably short of a small summary, so the SARS coronavirus is the result of a mutated animal virus. We do not know exactly how many steps of mutation were happening. What we know is that the SARS coronavirus now in the human body mutates continuously. So we have quite a number of mutations, hundreds of mutations, in fact, but only a few are giving rise to concern. Which mutation develop is rather unpredictable. So we cannot be sure when and what happens. The biological properties of viral variants are not foreseeable whatsoever. So you never know if a mutation wherever in the genome will make the virus more aggressive or less aggressive or something. And this is probably the major reason, or the main reason, for a close monitoring, that means viral sequencing, of newly developing variants. And this virus sequencing is crucial for the progression of the pandemic. So if you see a variant, then you have to or undertake certain measures. Next slide, please. And which are the critical points or the critical proteins for mutation? This is a cartoon of the virus, and you see there are 4 major structure proteins, and one of them, there's a spike protein that actually binds to the receptor, so the entry molecule into cells. So virus mutations in the spike protein could alter the virus entry into cells, and the cells need to be infected, otherwise virus does not replicate. It may hinder the recognition by the immune system, and by this may interfere with the development of individual immunity or the community immunity, so the herd immunity. So mutations could be very important in this respect, and ultimately have an impact on the vaccine development, because, and this is already well known, or there are hints in the literature that certain mutations in the spike protein may reduce the efficacy of certain vaccines. This is another important point. Next slide, please. So I have talked about the SARS coronavirus mutations, and now one of the questions that needs to be answered is, could it be that immune-compromised patients are probably favoring mutations? So do more mutations occur in immunocompromised patients? That in a way could be true, but it has not really been shown so far. But we know that patients with, or persons with a reduced immune response could generate or allow mutations to expand in the individuum. The question, of course, immediately coming from this point, should they be should patients or patients with an immune compromised disease, should they rank higher in the vaccination priority list? This, of course, is a matter and will be decided by the national governments. But just from the scientific standpoint, I think there's good evidence to say yes, they should probably rank higher and get probably a preventive treatment. That's probably not the point here, but it's they should be vaccinated. And well, is there a measure, a specific incidence of COVID-19 immunosuppressed? I think the data are not sufficient to really say that for sure. And does vaccination really help to reach herd immunity? I think for the time being, the percentage of the population in different countries is not high enough to be any near herd immunity. That may be close, for example, in Israel, but definitely not in the European countries. So herd immunity is not directly, but only in the long run may be important, or the herd immunity may be reached by vaccination. So I think this is basically what I wanted to say, and thank you for your attention.
Thank you very much, Professor Liebert. That was quite interesting indeed. And thank you for having answered the question we asked up front.
Yeah.
So I think we can now begin with trying and answer the questions that have been asked by the audience. I will start with the first one, and Zach will, of course, complete. The first one is probably addressed to the clinicians. Are there plans for all immune-compromised patients to be monitored after vaccination to check if antibodies hold up? There are strong doubts from how the vaccination will work for this vulnerable group.
Do you want me to answer?
Yes, please.
Okay, I can answer for CLL. I think that, of course, there has been already discussions, and we have a national plan to study the immune response to COVID-19 vaccination in CLL patients. We hope that we'll be able to merge this data with data from other countries. And but right now there is not yet a very this is not yet organized, but we are organized in France because we have started vaccination of immune compromised patients about 2 weeks ago. And so we'll be able to do it quite soon.
Thank you. Zach, a question perhaps?
Yeah, Dr. Patel, do you want to comment from the perspective of acute leukemia on the same question?
Sure. I think certainly in the UK and for acute leukemia as well, there are wishes to study this, and I think it's quite clear it's very important. It's a very important unanswered question to address. There are differences in different countries. In the UK, everybody with acute leukemia or chronic leukemia is classified as clinically extremely vulnerable, and in the tiered vaccination program, those patients are in the fourth group from the top, and those patients are, are going to be routinely vaccinated. In terms of the antibody response, I think it's already been sort of alluded to by the others that actually the antibody response alone may not be the best measure of protection against this virus, particularly in this immunocompromised population. Particularly also, as I illustrated, that the B cell numbers are very low in some of these patients. And so some measure of T cell function as well as B cell function is important. So those studies are ongoing. So for example, there is a study in the UK looking at patients who've developed COVID-19 in post-transplant, and most of those patients have acute leukemia, and that is collecting blood samples to try and address this question. But there are challenges because, of course, everybody's vaccinated. So there will be an antibody response from vaccination. The antibody response should be against the spike protein rather than other moieties like, for example, the nucleocapsid. And so although there are antibody assays against those other moieties, they're not readily available in the UK. So in terms of a standard of care assessment, that's really not possible today in the UK and in most countries. But in terms of clinical studies, yeah, those samples are being collected systematically.
Okay, thank you.
May I just say something? Because we have an assay that is readily available in France for antibody against spike protein. So there are even several, so you don't have that in the UK.
So there's I suppose, two issues. One is the spike protein assay is not going to be particularly helpful for the UK population. A lot of the patients with CLL and ALL either have been or will soon be vaccinated. And so the spike protein you would expect to tell you something about vaccination rather than about infection per se. So patients who get natural infection will get antibodies against spike, but also other surface protein or other proteins in the virus. And in terms of access, so these tests are available, but they're not clinically available because I think they've just been requisitioned and resources have been pooled and redirected to the national effort rather than making these assays available to small labs. But I think they are going to be crucial in the future, and samples are being stored and taken systematically.
So a really interesting question we've had here about whether the vaccine impacts on transmission of the virus. And maybe we could start with Dr. Delgado. But if we know that it might do to some extent, why are those who live with the clinically extremely vulnerable, are they being prioritized, and should they be more prioritized?
Okay, thank you for the question. Well, what we know about the vaccines, the approved vaccines, is they've been approved because they prevent severe disease. And this is what they do, and this is why they've been approved. So there's still a lot to learn about virus transmissibility. We don't know that for sure. But the good thing is that a lot of information will be provided to the EMA because of this conditional marketing authorization. So we'll have that information very soon. So what we know for sure is that it prevents severe disease. That's what we know for sure. Regarding prioritization, Well, the EMA has evaluated all risk groups. It has evaluated all possible populations, and it has decided that the benefit risk is positive for all those groups. So that includes cancer patients, that includes pregnant women, it includes all sort of situations. But it's not really within the EMA's remit to decide who should get the vaccine first. So the EMA is there to decide whether it is safe, whether the benefit risk ratio is positive for that particular group, but not really to decide who should be first and who should be second.
Well, thank you. I have well, I guess a silly question about the regulation. If we have a look on the decision of the different regulator, be it FDA, be it EMA, be it the health regulator in the UK, we see, well, let's say, significant differences in the delay for becoming, for getting a decision, and also a discrepancy about the recommendations. For instance, AstraZeneca being well, applicable to the elderly people or not. Do you have an explanation? It's a silly question.
Okay. So, I mean, regarding the differences between EMA and other regulatory agencies, the main difference is that the EMA has decided to grant conditional marketing authorizations to this. So the EMA is not trying to get what it's called an emergency authorization use, as other regulatory agencies have decided. So the EMA decided right from the beginning that it will expedite as much as they could the scientific assessment, but the final goal was always to grant a conditional marketing authorization, because that allows for rigorous evaluation of the vaccines. And so, you know, you have to make sure that all standards for safety, efficacy, and quality are there. And very importantly, that no European country is left behind. So that was the decision that was made. Other countries have gone for emergency authorization use authorizations, and these are different. These are temporary authorizations for supply and use. These are not marketing authorizations. And these are available at the level of individual EU member states. So these emergency use authorizations are governed by national legislation, and the EU cannot really, does not have that mechanism. It cannot grant that type of authorization at the EU level. So that explains partly why there are differences. Regarding the age issue, well, the EMA evaluated the AstraZeneca vaccine, and there was 13% of the population was older than 65. And the EMA actually decided that the benefit risk ratio for that population was positive. So actually, the EMA granted a conditional marketing authorization that includes patients older than 65. So from that point of view, there's no discrepancy.
Thank you. A very interesting question.
Very clear. Thank you.
That
Excuse me.
we've had it's fine. We've had a good question in as to many of our audience are patient advocates and representing patient organisations. Should we as advocates and organisations encourage our patients to accept a vaccine when offered? Maybe Professor Sibalista, you could comment first for CLL.
Well, am I mute? Can you hear me?
No, we can hear you.
Okay. Oh, definitely yes. I think that even if we don't have any real data showing the efficacy of the vaccine, even if the efficacy is reduced, I think that we are quite on the safe side. And I would say there is no reason why the safety of this vaccine should be different in immune-compromised patients. And considering the efficacy, even if it's reduced, it's better than nothing. So I think definitely patients should be vaccinated. And I would say that there is also a level of emergency to try to vaccinate the patients who are the most fragile, which are the ones who are treated or have been recently treated.
And the same question to Dr. Patel for acute leukemia. And are there any circumstances in which you would say, no, we shouldn't be vaccinating acute leukemia patients?
So in a word, yes, everybody should be vaccinated. You wouldn't want to vaccinate if there's a contraindication specific to the vaccine in relation to allergic responses or autoimmune disease or something that the vaccine label itself says is a contraindication for whichever vaccine the patient is offered. But if there is no contraindication, everybody should be vaccinated. In terms of when you could do it, I suppose the patients you might not want to vaccinate are the patients who are newly presenting, who haven't started treatment yet. Those patients, if they need urgent treatment in the next few days or week, those patients really should be treated and don't really need to be vaccinated at that point. But then subsequently, after recovery, I think those patients can be vaccinated. Otherwise, patients who have had some treatment and recovered or completed treatment and recovered, all of those patients should be vaccinated unless there's some other medical sort of reason why that shouldn't occur. In the post-allo setting, patients typically should be vaccinated 2 to 3 months after the stem cell transplant has occurred, can be vaccinated earlier. It's not recommended in the UK and in Europe. The timelines slightly differ, but the recommendation is that patients who are still having immune suppression therapy or lots of treatment for acute or chronic graft-versus-host disease perhaps may not get a great response and may not benefit fully from vaccination. I have to say, from our perspective in the UK, because we have no control over vaccination slots, which are allotted in the community, unless there's a strong contraindication to vaccination, actually we say to patients, whenever you're offered a vaccine, just take it, regardless of the other circumstances I mentioned in the post-transplant setting. Again, post-CAR T therapy, the recommendation in the UK is to have it after 6 months, but there is no real data, as everybody has discussed. So we've taken a pragmatic view that the B cells are not going to recover for perhaps longer than that. So as long as the patient's recovered from the therapy, so that's usually 1 month, the patients can be vaccinated if they're offered.
Thank you. I see here a quite global question, focused on immunodepressed patient, of course. Does the panel agree that there is a need of biomarkers in place in the future to inform immunocompromised people about their individual level of protection after vaccination? Otherwise, we face lifelong shielding as long as this virus circulates.
Should I say something about that, Pierre? If you're vaccinated, then that should not be the case. So if a patient is vaccinated, they should develop some level of protection. And we talked a few moments ago about how that can be measured and the challenges that in terms of measuring the level of protection and what the challenges might be. But if somebody's vaccinated, then actually they should get at least some degree of protection.
I think we also have to hope for at some point some herd immunity that will. I don't think that we'll be able to have the possibility to test everybody for protection, and I'm not sure we have the right tools right now developed for in the community. But we're certainly working on it.
So another question, and I'll go to you, Professor Simlisted. Are you giving any guidance to your patients on the different types of vaccines and whether they should have a preference for any of those vaccines, or do they just take the first one that's offered to them?
Well, I try to explain the differences in the vaccines the way I explain them to you, but they have no choice. They get what they are given. So and right now they are not given anything. So the problem is that we are really short in vaccines currently in France. Only patients who are above 75 can get vaccination outside of the hospitals. Myself, I have tried, I was able to vaccine over 40 patients by getting some Pfizer vaccines from the hospital, but it was a long fight. And I think it's right now, from what I understand, in France, the AstraZeneca vaccine will be distributed only to the younger patients. And I think that they should get what they should get the earlier.
Thank you. And a similar question to you, Dr. Patel, about acute leukemia and particularly from the UK.
So I think the first thing to say is there is really no data to justify, one vaccine over another for our patients. And the pragmatic view then taken by most people in the UK is whichever vaccine is offered is likely to be beneficial. So we don't provide a preference, and there is a vaccination schedule which is gone down. Actually, I have to say it is extremely surprisingly efficient how good it has been, and I might see a patient in clinic 1 week, I see them the next week, and they've already been vaccinated. it's a very efficient machine. So I think whichever vaccine is available, that's the one that should be taken.
In this respect, a question. Excuse me, Zach.
Sorry, go on after you, Pierre.
Okay. In this respect, a question about the prioritization of the different patients. How can we lobby in different countries, of course, to get higher priority for the immunodepressed patients, such as CLL or AL patients?
Well, I think that it's always very important to have patient advocates helping us to promote what we are asking. I think that at least in France, it has been heard that immune-compromised patients should be on the top of the list. I think that right now the shortage that is present now is going to be relieved, and we'll be able to vaccinate more widely. I don't know for other countries how you can help.
Other opinions in the panel?
No, perhaps we'll move on to a different question then. So Professor Libert, you mentioned during your talk that there was an increased likelihood that those who were immunocompromised might develop more mutations. Could you maybe expand on this a little bit more? We've had some questions about it.
So if you have an immunocompromised patient or a person with immunocompromised disease, then you're less able and less efficient in combating the virus. So the virus and the viral genome stays for an extended period of time in the body. And since the rate of mutation depends, of course, not only on the length of the genome, but also on the time the genome is present. So this is just a mathematical likelihood, it's a statistical likelihood that you have more mutations. We have seen in very few patients in Leipzig, that immunocompromised patients tend to have a higher viral load and for a more extended period of time. And that's the basis why I say mutations could occur.
Okay.
In this respect, Professor Liebert, as we see that several mutations are occurring, most of them rather concerning, let's say, do you expect that we will have to be vaccinated once a year, depending upon the different mutation that could occur in the future?
Well, it's a good question, but we all do not know how long our immune response persists after natural infection and after immunization. So it could well be that after a year or after 2 years, or probably after 6 months, we have to revaccinate. And so the data are not sufficient to exclude this. But I think for the time being, the mutations that we have discovered so far are really all probably where the vaccines really protect from all mutations that we see to more or lesser extent. So, for example, there's this South African mutation that may have will be less efficiently protected from by several vaccines. And so the question is, how fast can we adapt the vaccines to a rising mutation? And so that is something what probably puts some advantage on the mRNA vaccines, because they can be adapted much faster than probably the vector-based or the protein-based vaccines.
Okay, thank you. A question to Dr. Delgado. I don't know this name, but it is a question from the audience. Is GAM COVID vaccine under investigation for approval? I don't know, what is it?
I suppose they mean the Sputnik, the Russian vaccine?
May well be, I don't know.
No, we have not received an application from that developer yet. The EMA has been in contact with the manufacturer, and that is publicly available because they've received scientific advice from the EMA. But we have not received a proper application. And the moment the EMA receives it, it will be published immediately in the website. As I said, whenever a rolling review starts, this is made publicly available.
Thank you.
Thank you. A question to Dr. Patel. We've heard a number of times in this webinar that acute leukemia patients and leukemia patients generally are likely to suffer, have reduced efficacy with regards to the vaccine. We've had a question about what exactly we mean by reduced efficacy. Do we mean patients are more likely to contract COVID, or do we think they're more likely at risk of severe illness even when they've had a vaccine?
Thank you, Zach. I think it is important to try and clarify what that term means. The first starting point is we don't have any information about how the vaccine is beneficial or not in terms of anti-SARS-CoV-2 immunity in any of the patients mentioned. The information that we use is extrapolated from other vaccines. So, for example, pneumococcal vaccine or influenza vaccine, where we know that even extremely immune-compromised patients can develop an immune response. In some patients, it's a similar immune response to those patients in the general population who we don't think have any immune paresis. But generally, we find that the immunity in terms of antibody measurement, which is the usual way it's measured, antibody levels are slightly lower in those patients who are immune compromised compared to the general population. there aren't really lots of data sets even for non-COVID vaccines in that regard. There are some, and Professor Sibilista mentioned some of those in her talk. But the worry about, well, what does it mean? Does it mean I'm going to, if I'm a patient, am I going to get severe infection? Am I going to be hospitalized? Or as the aim for the vaccines is it going to provide enough protection so that only mild infection occurs? We don't know is the place we're at the moment. But if we were to speculate, we would expect that most patients will get some protection, and that protection would manifest as reduced intensive care unit and reduced hospital sort of admissions in terms of severity of COVID.
Okay, I see some question to Professor Sibilista, all focusing on the ideal time where the patient should be vaccinated. Is it before the treatment? Is it after the treatment? Could you precise this schedule, ideal schedule, so to say?
Okay, well, I think we can't always choose. I think if there is a choice to postpone the initiation of a treatment, it should be done. Because in CLL, not all treatment are emergencies. So if you can decide to vaccinate the patient and then start the treatment after the second dose, I think it's probably better. Patients who are on treatment are likely to have a reduced response to vaccine, but we have no choice. So once they are on treatment, I don't think that there is a specific time. They should be vaccinated at any time. And for the patients who have received treatment before, I mean, it's the same. They can be vaccinated at any time. The earliest, the better.
Thank you. Zach, any further question?
Well, we have lots and lots of questions
yes.
that we've not been able to get to.
2 or 3 of them, huh? Not more.
Yeah, exactly. I think just we have pages and pages of questions coming in, so it's great to see the engagement from everybody on the topic. And I should also take this time to thank all of our speakers for joining us. Lots of difficult questions, and apologies for throwing them all at you. But I think we'll end with a final question to kind of really summarize and maybe get everybody to comment on this question. If you were talking to a leukemia patient with either CLL or acute leukemia, and you were trying to convince them to have the vaccine, what would be your overwhelming message? So Professor Sibilista, maybe you can go first.
And what do I say to a patient who says, I don't want to be vaccinated? Is that the question?
Yeah, I mean, maybe someone who's unclear, unsure as to why they should have it. How would you summarize the benefits to them?
I think that I try to convince them by explaining the way it works. I think that I'm a great believer of pathophysiology. So I think that explaining how it works sometimes and showing that myself I got the vaccine is a good way to convince them. Right now, I had very, very few refusal. And I think that my final argument is that it's better to have a reduced efficacy than no efficacy at all. And very often the last argument is that they will be able to see their grandchildren more often and with less difficulty.
Thank you. Dr. Patel?
Yeah, I would agree with that, actually. Yeah, I think I can't think of any patient who has not been vaccinated that's been offered one. I think that the vaccine does provide an opportunity to at least prevent death from severe disease and hospitalization. And although there's uncertainty about the numbers in terms of the available data, I think it's clear that the vaccines are safe, and therefore it's something that we would recommend. And I have to say that there's been very little pushback that I've seen from patients, and like Professor Simbalista, you know, we've all been vaccinated. I you know, including myself, colleagues working in the hospital, and I think most of the older population in the UK has also been vaccinated. So it is, you know, I think it's much less of an issue than perhaps historically vaccines have, you know, have had in terms of challenge and pushback.
Dr. Delgado?
Well, I'm not practicing medicine right now, and I wish I could show them a badge like Professor Simbalista has, but unfortunately, since I'm not having contact with patients, I haven't been vaccinated yet. But I envy her for her vaccine. I will focus on safety. I will focus on safety. All the vaccines that are approved are safe in immunocompromised patients. And we tend to have these conversations with patients all the time. For the flu vaccine, there are lots of this happens all the time. So this is not a new conversation for hematologists, actually.
Thank you. And the last word to Professor Libert.
Well, the answer is very easy and has been said already before. The vaccines are safe. To get vaccinated is better than to stay unvaccinated. And if I had a choice, or friends of mine in my age group, I would say, get vaccinated. This is important, and be happy that you could get the offer of being vaccinated.
Thank you, Professor Liebert. It's a fine conclusion to my point of view. I thank you very much to all the speakers, to the audience that asked a lot of questions. And let's say, well, the conclusion has been yet established. Get vaccinated, recommend vaccination. And we are far from being at the end of this story. And I guess we will have the opportunity to organize another webinar as soon as possible, or better said, as soon as we get some more information about those sensitive questions and very interesting questions. Thank you to all.
Thank you.
Thanks a lot.
Thank you from me as well to everyone for joining. Nice to see you all and see you again in the future. Take care.
Thank you. Bye-bye.
Thank you.
Goodbye.
Thank you. Bye-bye.
Bye.
Bye.